We'll continue prostate cancer, part 15. Complication and side effect for radical prostatectomy. Sexual dysfunction. Erectile dysfunction post-operative rehabilitation might help recovery of erection. Post-operative potency is better when pre-operative erectile function is good. Age is less than 60. This is post-operative potency if the age is less than 60. Nerve sparing is performed by lateral nerve sparing result in higher chance of potency than unilateral nerve sparing. Loss of penile length. Approximately 70% of men will have a lifelong decrease in penis means loss of length equal 1 centimeter range of 0 to 5 centimeter loss. So approximately 70% of the men will have lifelong decrease in the penis length. Aspermia men will have lifelong absence of ejaculate fluid when they have an orgasm, dry orgasm. So aspermia. Urine incontinence with sexual arousal and with orgasm more common in the first year post-surgery, they tend to improve. So this occurs within 1 year, first year post-surgery, urine incontinence with sexual arousal or with orgasm. Pain with orgasm discomfort may occur in 20% of men, up to 20%. So stress urinary incontinence, SUI, often occur but usually improve during the first year after surgery. Younger men recover continence more completely than older men. So chronic severe stress urine incontinence probably occur in less than 5%. Preservation adequate urethral length during radical prostatectomy help maintain urinary incontinence. Bladder neck and anastomotic stricture occur in 1 to 2% of cases. Anastomotic stricture increase the risk of long-term urinary incontinence. Other risk infection, bleeding, inguinal hernia, and rectal injury are rare. Prognostic factor obtained from radical prostatectomy, surgical pathology. Positive surgical margin. Men with positive surgical margin are more likely to recur. Approximately 50% of men with positive margin will recur. A positive surgical margin is associated with higher risk of death from prostate cancer and lower overall survival. In men with a positive margin, adjuvant radiation or external beam radiation decrease biochemical recurrence and may improve overall survival. The most common site of positive margin is apex for open and robotic retropubic prostatectomy and anterior for open perineal prostatectomy. Positive margin are more likely to occur with higher preoperative PSA, especially PSA more than 10 nanogram per ml. Higher Gleason score, especially Gleason of more than or equal 8. Higher clinical tumor stage, especially T2B or T4 or T2B to T4, and higher number of positive prostate biopsy. All this considered as positive margin more likely to occur with this group. If we have higher preoperative PSA, especially more than 10, or higher Gleason score more than or equal 8, or high clinical tumor stage T2B to T4, or higher number of positive prostate biopsy. The size of negative margin does not impact prognosis. In other words, close margin achieve the same cure rate as an ample margin. Therefore, a close margin should be considered as truly negative. The extent of the positive margin impact prognosis with higher rate of recurrence in men with a large positive margin. Capsular penetration Gleason score of 8 to 10, seminal vesicles invasion, and lymph node involvement are all associated with high risk of developing cancer recurrence. So distal metastasis also, or distal metastasis and death from prostate cancer. This capsular penetration, Gleason score 8 to 10, or seminal vesicle invasion or lymph node involvement, this 4 factor is associated with high risk of developing cancer recurrence, distant metastasis, and death from prostate cancer. Grossly positive lymph nodes appear to have a worse prognosis than lymph nodes with micrometastasis. Treatment of positive lymph nodes found during radical prostatectomy. Traditionally, radical prostatectomy was abandoned when the positive lymph nodes were found during surgery. However, retrospective data show that when the lymph node metastases are found during pelvic lymph node dissection, radical prostatectomy improve overall and cancer-specific survival compared to abandoning radical prostatectomy. Therefore, radical prostatectomy should be continued when there is incidental finding of regional lymph nodes, metastasis during pelvic lymph node dissection. So radical prostatectomy should be continued if we find regional lymph node metastasis during radical lymph node dissection. Both radical prostatectomy treatment option for lymph node positive or pathology nodal disease include observation, lifelong castration, and pelvic radiation with lifelong castration, or pelvic radiation with lifelong castration. So this is options for PN1 disease: observation, lifelong castration, or pelvic radiation with lifelong castration. Observation after radical prostatectomy non-randomized study report that a 10 years cancer-specific survival for up to 60% to 70% in pathology nodal 1, men who underwent radical prostatectomy followed by observation with palliative and regime deprivative therapy for clinical progression. Observation may be most appropriate in men with less than 2 regional lymph node metastasis because they have higher cancer-specific survival. For example, that Schomscher et al. 2008 showed that among BN1 men who underwent radical prostatectomy followed by observation, 10-year cancer-specific survival was 78.6% in men with less than or equal to positive nodal and 33.4% in men with more than 3 positive nodes. Long-term ADT after androgen deprivation therapy after radical prostatectomy ECOG 3886 studied men who underwent radical prostatectomy with pelvic lymph node dissection and who had microscopic pelvic lymph node metastasis. So men were randomized after radical prostatectomy to observation or lifelong castration. At median follow-up, up to 20 years, overall and disease-specific survival were significantly better for castration better than observation. Non-randomized study and meta-analysis showed no survival benefits to castration in this setting. However, immediate castration may improve survival in men with microscopic pelvic lymph node metastasis who underwent radical prostatectomy. Radiation and long-term androgen deprivation therapy after radical prostatectomy in men with pathology N1 who underwent radical prostatectomy retrospective data show that both operative radiation and androgen deprivation therapy result in higher cancer-specific survival and overall survival than either post-operative anti-androgen deprivation therapy alone or observation alone. The NCCN guidelines state that men with lymph node Metastases found at radical prostatectomy should be considered for immediate anti-androgen deprivation therapy with or without radiation. Radiation therapy after radical prostatectomy. Adjuvant radiation administered for non-residual cancer after radical prostatectomy postoperative PSA is detectable or for increased risk of possible future recurrence. Postoperative PSA is undetectable, but the patient has adverse pathological finding at radical prostatectomy. It is usually delivered after the patient regains adequate urinary incontinence, example, 4 to 6 months after radical prostatectomy. Salvage radiation administration for local recurrence of cancer, post-operative PSA was undetectable but subsequently became detectable. In the post-operative radical prostatectomy setting, radiation dose to the prostatic fossa should be at least 64 to 65 gray as per an AUA 2019 guideline. The role of adding androgen deprivation to the post-prostatectomy radiation is unclear. Severe radical prostatectomy test. The molecular test is performed on cancer from the radical prostatectomy specimen in men who are candidates for post-radical prostatectomy radiation. They have biochemical recurrent seminal vesicle invasions and extra prostatic extension or positive surgical margin. So high disease score correlate with higher risk of developing metastasis and death from prostate cancer. Men with low score have a similar risk of developing metastasis whether they are treated with adjuvant or salvage radiation. Thus, this men may be more optimally managed by surveillance with salvage radiation as needed. In men with an average or a high risk score, salvage radiation associated with a significantly higher risk of developing metastasis than adjuvant radiation. Thus, this men may be more optimally managed with adjuvant radiation. Adjuvant radiation versus observation. 4 randomized trials have evaluated adjuvant radiation versus observation after radiation. SWOG 8794, EORTC 22911, ARO 69.0, and fine prostate. All this is in adjuvant radiation versus observation. These 4 trials, the sum of evidence from these trials indicate that the N0 M0 men who are radical prostatectomy pathology show extra capsular extension, seminal vesicle invasion, or positive surgical margin. Adjuvant radiation reduced biochemical recurrence and also local failure and clinical progression compared to observation with median follow-up of 9 to 12.5 years. It is unclear if adjuvant radiation improves overall survival, that is WOG 8794 showed an improved overall survival with radiation, where EORTC 22,911 and ARO 69202 and did not. It is unclear if adjuvant radiation improved metastasis-free survival. SWOG 8794 showed that improved metastasis-free survival with radiation with erotic 22,911 and ARO 96 to 02 and fine prostate were not powered to assess metastasis-free survival. Adjuvant radiation achieved greatest reduction in recurrence for men with positive surgical margin. However, men with extra capsular extension or seminal vesicle invasion still appear to benefit from adjuvant radiation. Men with receive adjuvant radiation are less likely to subsequently receive hormone therapy. The ASTRO and AUA 2019 guidelines state that the physician should offer adjuvant radiotherapy to patients with adverse pathological finding at prostatectomy, including seminal vesicle invasion, positive surgical margin, or extra prostatic extension. Because of demonstrated reduction in biochemical recurrence, local recurrence, and clinical progression, but the impact of the adjuvant radiotherapy on subsequent metastases and overall survival is less clear. Adjuvant radiation is unlikely to cause urinary incontinence, but it increases the risk of proctitis, erectile dysfunction, and urethral stricture. Adjuvant versus salvage radiation among M0 with undetectable PSA after radical pathological risk for recurrence, 3 randomized the gravis are radicals and GETA and AFU17 show no difference in biochemical progression between adjuvant radiation, and salvage radiation. Median follow-up 5 to 6.9 to 6.5 years. Also, salvage radiation resulted in less grade, more than 2 genitourinary toxicity, including lower state of urinary incontinence and urethral stricture, and less grade 2 erectile dysfunction. In this study, pathological risk for recurrence were positive surgical margin, stage BT3, extracapsular extension, and or seminal vesicle invasion, and or Gleason score 7 to 10. Salvage radiation was administered with a few months of recurrence, and recurrence was primarily defined as BSA more than or equal 0.1 to 0.2. Only 10 to 20% of patients in these studies had multiple risk factors for recurrence. When the post-operative BSA is undetectable in men with adverse pathological finding on radical prostatectomy space, observation avoid unnecessary radiation in patients who are cured by radical prostatectomy alone. Furthermore, in these patients, observation is with salvage radiation for recurrence, a key equivalent cancer control, and result in less severe side effect compared to adjuvant radiation. Given the data described above, observation with salvage radiation, if local recurrence occur, is probably the preferred option in men with undetectable BSA after radical prostatectomy and one pathological risk for recurrence, positive surgical margin, BT3 or Gleason score 7 to 10. Adjuvant radiation may be more suitable for men with unfavorable decipher radical prostatectomy score, or for men with more than one pathological risk factor for recurrence. This is the end of part 15. Bye-bye.